Good morning. Can everyone hear me, or at least those that I have unmuted and video? Can you hear me, Dr. Molina and Deanna?
Yes, I can.
Yes.
Wonderful. All right, we're going to begin this National Spotlight Speaker Series. Good morning and good afternoon to everyone zooming in from across the country to join in conversation with the National Association of Latino Healthcare Executives. I am Rolando Gomez, President and Board Chair of NALHE, and it gives me great pleasure to welcome you to our National Speaker Series. We have the honor of hosting Dr. J. Mario Molina as our Spotlight Speaker and Deanna Caudillo, 2020 Chair of the NALHE Annual Leadership Summit as the moderator. We're incredibly thankful to you both for spending time with us today. Before we begin, we ask that you please silence your audio, disable your video, and submit your questions via the Zoom chat box. We have allocated time for a moderated Q&A with Dr. Molina after his presentation. For your viewing preference, we recommend you utilize the side-by-side option found in the View Options tab. If you are new to the NALHE family, I'd like to take a couple minutes to briefly introduce you to our professional association. NALHE is an organization with a little over 15 years in the making. Our mission and vision speak to the nature of our existence. We are an association of healthcare leaders committed to fostering a culture of authenticity. We champion diversity, equity, and inclusion initiatives, and we promote and advance varying perspectives and ideas that provide opportunities for Latinos and Latinas to have a role, a voice, and a seat at the leadership table. The NALHE footprint spans across the US via multiple chapters. Our growing member and partner networks represent students, early careerists, and mid to senior level executives, physicians, nurses, and other industry professionals. NALHE is proud and thankful to have national health industry partners and sponsors. Together, we ensure that we are advancing our mission and that we create opportunities for leadership, professional development, and career advancement. We offer numerous educational, networking, and professional development programs and events for our members and partners. We welcome you to join and connect with NALHE to learn more about our member benefits and partner opportunities. Visit us at nalhe.org or learn more about our COVID-19 initiatives at nalhe.org/coronavirus and connect with us via email at info@nalhe.org. So with that, enjoy the conversation today, and thanks again for joining us. I'd like to now hand it over to Deanna Caudillo. Deanna, the floor is yours.
Thank you, Ro. Good morning and good afternoon to everyone. Thank you so much for taking the time to join us today for this important and timely discussion. I am Deanna Caudillo, current president of the Denver Metro chapter of NALHE, the chair of the Leadership Summit, and co-chair of the NALHE COVID Taskforce. Thank you, Rolando, for sharing the work that NALHE does for healthcare leadership and providing us with an overview of where NALHE is going in the future. It's a responsive organization that offers its members an amazing opportunity to be a part of the change they want to see in the healthcare leadership space. I also want to take the time to thank all those members of the NALHE COVID-19 Task Force who have worked tirelessly to make this event a reality. They're diligently crafting articles, podcasts, and webinars to bring relevant content to this issue as it impacts NALHE members and those who are invested in healthcare leadership during this challenging time and for years to come. So with all that said, let's move into our spotlight speaker for today. I am very proud and honored to introduce Dr. J. Mario Molina. Dr. Molina earned a medical degree from the University of Southern California and performed his residency in internal medicine at Johns Hopkins Hospital, followed by a fellowship in endocrinology at the University of California, San Diego. He received a certificate in management from the Anderson School of Business at UCLA. He served as a faculty member at USC before joining Molina Healthcare. In 2005, Time magazine named him one of the 25 most influential Hispanics in America. In 2013, he was awarded an honorary doctorate by Claremont Graduate University. Modern Healthcare listed him among the 100 most influential people in healthcare. He is a trustee of Johns Hopkins Medicine and served on the visiting committee for the Harvard Medical School. We're very excited that he has taken the time out of his busy schedule to join us today to discuss the impact of COVID-19 on healthcare communities. Dr. Molina, thank you so much for joining us.
Well, thank you. I'm very honored that you invited me to join the group.
Well, thank you. So we're just going to kind of jump into the questions we have today. And the first question is, for those that have recently lost healthcare coverage for a myriad of different reasons, what resources are available to them?
Well, as you probably know, through the Affordable Care Act, healthcare was expanded to many low-income persons. And if you've lost your job, you have what's called a qualifying event, which allows you to shop for healthcare in the marketplace. Many states have their own marketplace, and those that don't use the federal government's website. So you can go to either healthcare.gov, or for example, here in California, we have Covered California, which goes by coveredca.org. And you can go there to find out if you qualify either for free healthcare through the Medicaid program or subsidized insurance through Marketplace. It's based only on your income. So for example, someone that lost their job in March, even though they may have had a well-paying job, might qualify based on the fact that they have no future annual income for the foreseeable time. I think that this is really important that people know that this is based on your income, and Medicaid you can qualify for all year round. On the marketplace, you have 60 days from the time that you lose your job and your insurance to apply for subsidized insurance.
Great, thank you so much. That's incredibly helpful information to have. Given everything that's going on right now with the myriad of different challenges between the pandemic and other confounding factors, what long-lasting changes do you believe will occur as a result of the pandemic?
Well, you know, I'm hopeful that we get a vaccine soon, but I think it's likely to be a couple of years. So the virus is going to be with us for quite some time, and most people will not have immunity. So we're going to have to change the way we deliver healthcare to deal with a highly infectious virus that is potentially lethal. Some people look at the virus and they say, well, it's really no worse than the flu. In fact, it's a lot worse than the flu. And in talking to people who've been involved in direct care of patients, especially in the ICU, it's very frustrating because they stand at the foot of the bed and there's very little they can do other than to offer supportive care. We have no treatment, we have no vaccine. And even the remdesivir only shortens the duration of the illness by a few days. It doesn't cure the disease, it doesn't prolong life. So this is going to be a very difficult situation for the entire healthcare community, whether you're on the ambulatory side or the inpatient side, or you're in the pharmacy. We're going to have to get used to, for the next several years, I think, changing the way we deliver healthcare. It's been tremendously stressful for healthcare providers and their families. You know, my daughter and her husband are both physicians down in Florida, and I know they worry about bringing the virus home to their families. And I know that many people, for example, doctors in New York, were incredibly stressed out by the volume of patients and the number of deaths.
Yeah, absolutely. I think that what we're seeing is it's definitely taking its toll on those individuals who are trying to provide the best level of care that they can, you know, and then trying to figure out how, as exactly what you were saying, try to keep their families safe. Absolutely. Thank you so much. What additional needs do you see healthcare executives being asked to deliver to their communities during this pandemic? And I'm thinking specifically about kind of two different baskets. So healthcare executives who are trying to support the needs of their staff, for sure, as those needs are changing day by day, and also some of the community sides of it, some things that they maybe are not used to getting into, but are being asked to get into at this time.
So Deanna, you're exactly right. Healthcare leaders operate in two spheres. The first is the organization where they work and supporting the people that work for them. So our first job is to support the people who are the frontline healthcare givers. And number one on their list is safety. So we've got to make sure that they have safe working conditions, that they have the protective equipment that they need, that everyone is getting the proper training that they need, anything we can do to support them in doing their jobs on the front lines. And that interestingly enough, I was talking to a woman who's a hospital administrator, and even though everyone's incredibly busy and incredibly stressed out, she told her staff she expects everyone to take a 1-week vacation, and she's going to hold them to that, because it's important not only to take care of the health of others, but to take care of your own health, and that includes your own mental health. You can't help somebody else if you are incapacitated. So it's important that we stay healthy, both physically and mentally, and that we support those people who are delivering the care. The second thing is, especially if you're in a not-for-profit organization, you have a community mission. And I believe that all of us have a mission to serve the community, whether we're in a for-profit or a not-for-profit company. And so what can we do to help the community? This has become especially important now because, you're seeing rioting all over the country. And this is due to a general angst. People are unhappy. They're unhappy about the economy. They've lost their jobs. They've lost their health insurance. They feel hopeless. On top of that, many people in minority communities are feeling the bias that's inherent in this country. And so we've got to be out there kind of trying to help them and help the country recover. It's going to be especially difficult in light of the rioting. But we've got to support things like food banks. We've got to get our staff out to help volunteer, to man those food banks, man drive-through testing sites. Whatever we can do to help the community is what we should be doing. And as leaders, encouraging our people to do the same.
Absolutely. Thank you so much. I think that's incredibly helpful. And you're right. I mean, in terms of the staff and the staff support, I've talked to a myriad of different CEOs, and they were talking about, trying to deal with childcare needs for their staff because the children aren't in school. And of course, if you're an essential personnel in the hospital, you can't stay home and do homeschooling if you're supposed to be in the ED. Helping people, or food delivery systems, or all of those different pieces to really speak to their immediate needs and to let the staff know that you've got them, that you're supporting them, and that you appreciate the fact that they're human beings and they've got families and they have other obligations. So
well, it's also important to remember that while doctors and nurses are bearing the brunt of the care, and they're on the front lines and they're constantly exposed to people with virus, lots of other ancillary people in the hospital are too. I mean, don't forget about the housekeeping people. Housekeeping is, again, a high-risk area where people are exposed to body fluids and, and potentially infectious materials. They are just as much at risk as the nurses and the doctors are. So it's everybody, and it puts a strain on everyone from the administrative staff, to the kitchen staff, to the cleaning staff. Everyone is feeling this.
Absolutely. Absolutely. Thank you so much. So I'm going to move into our next question, which is, what is the role of healthcare leaders, kind of thinking in a broader piece, in crafting legislation that supports social programming? You were talking about some of the community-related services. So what do you feel like the role of healthcare leaders are in helping to kind of bring a voice to the table regarding legislation?
Well, as leaders, I think our job is to serve the people that work for us, that sort of servant leader model. And so there are lots of things that we can do, but one of them is advocacy. And I've been very involved in that because when you talk to legislators, many of them have no healthcare background. And they're being asked to craft policies or pass legislation, and they really don't understand healthcare. So it is really critical for us as healthcare leaders to explain to our legislators and our regulators what's important, what we need, and also what we don't need. Because overregulation or things that get in the way of delivering care are just as important as bringing in new rules, new regulations, and new funding. So I think that that's an important role that all leaders can play, regardless of where you are, whether it's talking to people at the city council, the county supervisors, the state legislature, or members of Congress. You have a job to be the liaison and help explain to people what's going on in this crisis and what your people and your community need.
Absolutely. Yeah. Well said. So we've got a question from the audience, and it says, how prepared do you think the industry was on the public and private side of the pandemic from the health insurance perspective? How prepared do you think they were?
Well, that's a great question. You know, the function of health insurance really is to pay for the care. So they're less involved in the direct delivery of care than are hospitals and physician groups. And I think that they're pretty well prepared. I don't think they were quite up to speed on things like telemedicine. And we're still seeing issues around reimbursement. You know, they've made lots of promises about what they're going to pay for, but actually getting payments has sometimes been troublesome. Billing issues. So for example, if you bill with the wrong codes, you don't get paid. They promise to cover things that are COVID related, but you know, how do you know? And in some cases, they'll say, well, there's no COVID test. So how can you bill for that? In many cases, we presume that people are infected and we treat them as if they were, and that's important. So I think I would give them about a C+. They've done okay, not great. They could do more. The other thing is I think that they could do a lot more to help in the community.
Yeah, absolutely.
There's that aspect of it too.
Yeah, and I think there's a very steep learning curve, and I really hope that you know, they're taking this opportunity to kind of learn and you know, create a playbook, because I'm sure that this is not going to be the last time we see something of this magnitude that's going to overtake our communities and our system.
Well, when you think about it, this is the third coronavirus epidemic we've had in the past 20 years. And I think, unfortunately, as a people, when this crisis passes, we tend to breathe a sigh of relief and just hope it never will happen again. Clearly, we know that we are going to face these kinds of epidemics or pandemics again and again every few years. And we really need to start thinking about how we prepare for the next one, not knowing where it's going to come from. Could it be influenza? Could it be coronavirus? Could it be something that we haven't considered yet? So I think that's another thing that we really need to learn from this experience and really plan ahead.
Yeah, absolutely, because we see the chaos that erupts when we are seemingly caught unaware of something that we were probably aware of. But as you were saying, you know, history has kind of showed us that these kinds of things come up, and it's a matter of kind of being prepared so that we've got mechanisms in place to support people, to you know, get services where they need to be, and kind of anticipate what gaps in the system. I think, if anything, this pandemic has shown where the biggest gaps in the system are, and where we're most vulnerable. So thank you. The next question is, how long do you anticipate it will take for the health insurance industry to settle into a business as usual state? I know that you were talking earlier about kind of looking at a multiple year time frame, but in terms of the insurance industry, how long do you think it'll take for them to kind of get a playbook in place and then be able to kind of roll with it?
You know, I think the insurance industry is going to be in pretty good shape by the end of this year. I think by then we will know enough about the virus, we'll know enough about the problems, we'll know enough about the healthcare delivery issues that we ought to be able to go forward for the next several years and handle those things. You know, again, the health insurance is really probably, I think, the smaller part of this. It's the frontline providers, the hospitals and the physicians and the medical groups that are really bearing the brunt of all of this. You know, the insurance companies are doing pretty well. They're getting premiums every month. And what we have seen at the end of the first quarter and into the second quarter is that because utilization has been very low, they're doing well financially. Hospitals and medical groups are struggling, especially providers that rely on fee-for-service payments. Those providers that are getting some capitation, some sort of prepayment, are in a better position to weather the storm than those that are strictly fee-for-service. We're seeing, you know, for example, primary care doctors' offices are really under a lot of stress. They have no income. They may have had to shut down. What happens if you have one or two providers in the office and the provider gets sick? How do you handle telemedicine if you are a small practice? Those kinds of issues are the things that we're really struggling with. So I think that the health insurance industry is okay. It's the other parts of the healthcare system that are really feeling the stress.
Yeah, absolutely. So I've got some more questions that are popping up in the chat, and I'm so glad that people are feeling comfortable in submitting these. It says, what areas of healthcare services are going to be most affected by changes? And you were talking about some of the fee for service and some of those pieces in the delivery, and some of the hospitals. I've heard conversations about financial solvency, about outpatient services, about just kind of readdressing the whole model in terms of how services are delivered and paid for, and what does that look like?
Well, I think it was Winston Churchill that said, never let a good crisis go to waste. This is a crisis, and it's going to force us to test all of our assumptions about how healthcare is paid for and delivered. We've talked for years about value-based care, but most care is still fee-for-service. And I think we need to start thinking more about how we get involved with prepayment of care to provide cash flow. I think we need to think about the role of primary care and how we deliver primary care. In the old days, we had large waiting rooms and we expected patients to come and sit and wait to see the doctor. That's not a good strategy right now. It's really propelled telemedicine. In talking to people, physician visits are down anywhere from 30 to 70%, let's say probably 50%. Some of that has been offset by telemedicine, but not all of it. So the other thing we have to worry about is what happens to preventive care. I think a lot of people are afraid to go to the doctor, especially a primary care doctor, for preventive services like immunizations. We don't want to end up 6 months or a year from now with a measles epidemic because kids didn't get immunized. Who should be immunizing people? How do we break down barriers to make it easier for everyone to get immunized? How do we make it easier for everyone to get the preventive services they need? Why should women need a referral, for example, to get a mammogram? And I think with electronic health records, it'll be easier for us to kind of coordinate things, but we still have the issue of interoperability. That's something we've got to solve. I can take my ATM card and go to any bank and get money, check on my account, etc. Why can't we do that in healthcare? Why are we so far behind other industries when it comes to interoperability? Hospitals are going to have to rethink the way they do business. I think hospitals are probably going to get smaller. They're going to treat sicker patients. Even talking to some of my colleagues now, they're telling me that the COVID patients that are being admitted are sicker now than the ones they saw earlier in the epidemic. And I suspect it's because people are learning that some of these patients can be cared for in an ambulatory setting. You don't need to be hospitalized. So it's going to change the way the hospitals operate. It's going to put more stress on hospitals. I think we're going to see more shifting of surgical procedures into outpatient settings. There's going to be a whole shift of changes. I just really think this is the time to rethink all of our assumptions about healthcare. I mean, we've always done it that way is not going to be an acceptable answer anymore.
Yeah, absolutely. I couldn't, well said. So somebody in the chat had a question about something a little closer to home. They said, in your opinion, what is the state of healthcare systems and infrastructure in Southern California and its readiness to deal with the pandemic?
That's a great question. We have a lot of federally qualified health centers here that provide care to low-income patients. They're struggling from what they're telling me because their reimbursement is based on a per-visit basis. So that's a problem. The financial model of the FQHCs, I think, needs to be re-examined. We talked about the struggles that hospitals are having. I think primary care doctors, likewise, are really struggling, whether they are, seeing Medicaid, Medi-Cal patients, or Medicare or commercial. It's a real problem. And I think one of the things that's going to happen as a result of this is further consolidation. So small doctors are going to kind of throw up their hands and join larger groups. That's going to mean some loss of autonomy, but it may mean greater financial security. It also means that it's important, I think, from the healthcare executive standpoint, you're going to play a bigger and more important role in designing the systems that deliver healthcare. Medicine is applied science. We take what we learn from microbiology and anatomy and chemistry, and we pull this all together and we treat patients. healthcare delivery should be the same. I mean, Peter Pronovost at Hopkins has shown us that you can make a science out of healthcare safety. I think the same is true out of healthcare delivery. We have got to make the delivery of healthcare a science. We've got to constantly study what we do and find ways to improve, and it's got to be based on data. One of the things that I found, you know, when I was CEO of a healthcare company was that people would come to me all the time with ideas and they would tell me things. And one of my favorite questions is, how do you know what you know? Where's the data behind this? Deming used to say, in God we trust, everyone else bring data. So we've got to become very quantitative about what we do and test our assumptions and find out what really works and what adds value. Because we do a lot of things, and sometimes I think things we do really don't add any value. Those things need to be eliminated from healthcare.
Yeah, absolutely. And on the data side, you were talking about some of those smaller neighborhood clinics, and I'm just thinking about when we have discussions with those patients who are accessing those clinics, what they typically say is, I go here because I like the way that I'm treated. I like that they speak my language. I like that they're culturally sensitive. I know I could go to this large hospital, but I don't feel as comfortable going there. And so I don't go there. And so figuring out a way to translate that level of trust within the community and take some of those pieces so that people are able to utilize the services where they're most efficiently kind of delivered, I think it should be part of the conversation moving forward.
Well, I'm a big believer in the patient-centered medical home. I think it can do a lot. All of our clinics that we ran were patient-centered medical homes. However, I think that we have underfunded primary care. I think primary care doctors and patient-centered medical homes could do more, but they need more funding. And that's one of the issues that I saw. You know, in our clinics, we could show that relative to the rest of the network, there was lower hospital utilization, but the providers weren't sharing in the cost savings from that. So if you're going to task someone with comprehensively managing care, you need to share the cost savings that come from that. And I think, you know, the same is true for hospitals. I think we're going to move to a more collaborative payment model, whether it's capitation or some sort of risk sharing arrangement, so that everyone shares in the upside. It may mean sharing on the downside too, but I think that's the future of healthcare payments.
Yeah, absolutely. We have a lovely question. I'm just going to kind of take it back to something that we discussed a few minutes ago regarding safety. And the question is, speaking of safety, how can we best communicate that it is safe to come into clinics and hospitals for regular visitations, like vaccinations and well baby visits and annual checkups? And I think, again, this kind of looks at the whole PR piece, because I think that people right now are scared, as you were saying earlier, to kind of come in. What I'm hearing from physicians and providers is that their rate of people who are dying at home is much higher than it's ever been, because people are delaying care even during critical situations. And so by the time they are calling 911 or an ambulance, it's far too late, and that person is kind of deceased in the home. So how do you envision that conversation happening with community members to kind of calm their fears and let them know that hospitals have always been safe, and they are safe now to kind of come in and get that care?
Ironically, hospitals and emergency rooms are one of the safest places in our communities. And the reason is that they have done such a good job of preparing for the epidemic. You know, I had occasion to go to an emergency room here not too long ago, and it was really impressive the way they handled the patient flow. So I think they are safe. I think they're very safe. I think that what we need to do is communicate that to the patients. And I think that you know, I had a mentor who used to say, to people that matter, we explain why. I think we need to start by telling people why these facilities are safe, why it's okay to go to the hospital when you need to. Now, we don't want to get back to a situation where people visited the emergency room for things that really didn't belong there. But I think that we should be emphasizing the steps that we have taken to make sure that their experience is safe, whether they're in the emergency room, in the hospital, or in a doctor's office. And part of that's going to be social media, because this has to be a grassroots effort. You know, you need to talk to your friends, you need to talk to your neighbors, we need to get this on Facebook, we need to get this out there on Twitter, whatever kind of social channels we have available to us to explain what's happening. There's a lot of fear and there's a lot of myths about the virus, and it creates confusion. And when people are confused, they don't seek care.
Yeah, absolutely. So kind of tapping into those social influencers within those communities, whether those are promotores or, whoever those people may be who, can serve as a touch point to disseminate that information, I think is absolutely critical. Yeah.
But all the executives can play a role too.
Absolutely.
You can get on social media and you can talk about what you are doing in your segment of the healthcare community, whether it's a hospital, a clinic, a pharmacy, and get the word out to people. The more people we have, the more voices we have delivering that message, the better it will be received.
Yeah, that's great. Thank you. So the next question comes in and it says, suggestions for healthcare organizations to address health disparities in minority and underserved communities. And we're certainly seeing that in the data, as you were, we were talking about earlier, the data in terms of, those individuals who are coming in, who are having poor outcomes. They're definitely disproportionate in terms of the overall population data when we look at the demographics. So any suggestions for healthcare organizations to address those pieces?
Well, we talk a lot about what are called social determinants of health. And I hate that term because it's very euphemistic. The bottom line is the reason that some people are healthier than others, the reason that some people get better care than others comes down to two things. And it's poverty and it's racism. It's really as simple as that. So we have to address those issues. Going back to one of the first comments I made, it's really critical that people become insured right now. Over 40 million people have lost their jobs. Many of those people will not have health insurance. Some of the ones that are furloughed have it for a little while, but you do not want to be uninsured in a pandemic. Length of stays for people with COVID run several weeks, not several days. These are expensive hospitalizations. So we all, as an industry, should be encouraging people to find out if they qualify for one of these state or federal programs and get insured. That is absolutely critical, and all of us can play a role in that. Because if you're insured, you have access to care. And if you're insured through the Medicaid program, for example, you have all 10 essential health benefits covered. You're going to get inpatient care. You're going to get outpatient doctor visits. You're going to get preventive care. You're going to get pharmacy. You're going to get rehab. You're going to get skilled nursing if you need it. All these things, it's comprehensive coverage. And that's one of the things people need. The next thing is, and this gets to advocacy, we need to begin working to change things in this country. We have lost the middle class. We are becoming a country of haves and have-nots. That's not good for democracy. And finally, education. When I was growing up in the 60s, blue-collar workers could earn a good living, be in the middle class, and that was with a one income earner family. Now many families have both husband and wife working, and they are just doing everything they can to keep their noses above water. We need to change that. So we need to change the way we pay people. Low-income people need to make more money, and we need to work at things like a living wage to lift people out of poverty. And we need for people to go to school, because the other thing that's happened is a lot of those blue-collar factory jobs that used to pay very well have been replaced. Some of them have gone offshore, but a lot of them have been replaced by mechanization, by robots. When you go to a factory and you see things being built, they're built by machines, not by people anymore. That means that you've got to get an education, because what's really going to be valuable in the 21st century are knowledge workers. So we've got to encourage our kids to go to school, stay in school, and do everything we can to help them and push them forward. When I was young, there were very few Latinos in medicine. And when I said to people, I want to go to medical school, they would say, well, people like you don't go to medical school. That has to change. But in order for it to change, people have to go to college. And it's become enormously expensive. So we've got to address that too. I went 2 years to a junior college, 2 years to a state college. And I was able to work while going to school. It's harder to get through school now than it used to be. It's more expensive, but we've got to find ways to help people. And I would not encourage students to simply go into debt. Junior college is a great option. Here in California, if you want to go to a UC school, you're better off to go 2 years to a junior college because the acceptance rates are higher for transfer students. So, I mean, it's all about changing the social fabric in order to improve healthcare.
Yeah, absolutely. And I think that's one of the things that I love about NALHE is that we're really very invested and committed to having individuals in those spaces so that, you know, when you're a little kid sitting in a classroom and they say, you know, what do you want to be when you grow up? You can look around and see other people that look like you and sound like you and have similar backgrounds and say, oh, I want to be a healthcare leader, or I want to be a doctor, or I want to be a whatever, because you see that it's possible. And so having those conversations about how we shift that narrative and that dynamic, I mean, it's just incredible. I'm in graduate school right now, and when I look at the statistics and the data about how many individuals, how many Latinos have graduate degrees and higher, you know, it's incredibly disproportionate to the overall demographics in our country. So having those conversations and showing up and creating a different narrative for the future, because I think it's really important.
Yeah, I think it's really important for the members of your organization to get out into the community and be role models. You talked about having a speakers bureau. You need to get into places like high schools. Kids in high school need to know that there is a path and that these kinds of opportunities are open to them because they see people from their community who have done it. That is really important. You know, I used to think that role models weren't really that important, but I've changed my mind about that. I think they're critical. I think young people need to know that there's a place for them in the world and that other people like them have succeeded and they can too.
Absolutely. So the next two questions, you were talking about education. So I just wanted to briefly ask about healthcare literacy. You were talking about kind of education in a general sense, but one of the things that I see is missing in the conversation is healthcare literacy. So how do we help facilitate those kinds of skills within our communities so that they can be informed consumers and really, you know, you were also talking about advocacy, how they could advocate for themselves and have a better understanding of those things that are impacting their health.
Yeah, I mean, it's not just the Latino community, it's people in general. They don't have a good understanding of health and healthcare, even basic biology. And I talk to people, you know, there are a lot of people that don't even know where their organs are in their body. So healthcare literacy is an important issue. And, you know, my sister formed the Molina Foundation, and they give away books. She and her husband, Tino, have been doing this for years. They've given away millions of books. And some of the books they give away are about how to take care of yourself when you get sick or how to take care of your family. People need that. They need things that are written at a lower reading level, that are simple, plain language. Here's what you need to do. And, you know, we can't simply rely, for example, on physicians to educate people. They don't have the time, for one thing. You know, doctors have a lot of patients to see. They're under pressure. They don't spend a lot of time talking to patients. So it really is going to depend on other people and other media to educate people. You know, I'm spending an awful lot of time right now on health insurance because people just don't know. Many people don't know what the Affordable Care Act is. They don't know that they qualify for insurance. They think, well, I was employed, now I've lost my job, I'm just going to have to go without. This is a problem. People just don't know. So all of us have to be educators, and we need to get out there and tell people, whether it's through social media, whether it's through a speakers bureau, you know, what they can do, how they can take care of themselves, and where they can go for information.
Yeah, absolutely. The other side, somebody had a question about, will the future of medical education change as a result of the pandemic? Do you see there being kind of a shift in medical education for how we're moving forward?
That's a great question. You know, I spent 6 or 7 months as the founding dean for a new medical school out in Claremont. I left because I felt that the crisis was not the right time to be starting a new medical school. This was really an all hands on deck moment. But I do think that medical education needs to change. I think it will change. For example, all of the medical students were sent home the last semester. They were taken out of the hospitals, they were pulled out of the classrooms because people were worried about the virus. We're going to have to confront that. If you go back 100 years ago, before the advent of antibiotics, medical students and doctors were exposed to infectious diseases. You had to deal with it. And there were no antibiotics, no treatments, very few immunizations. We're going to have to learn to deal with this and teach the students. But I think we do need to re-examine the way we educate people and what we expect of physicians. Unfortunately, change in medical education is slow, and there is an accrediting body for medical schools. Medical schools are reviewed every few years. They have to be accredited, and it's really difficult to make change in an existing institution. That's why I was so excited about the opportunity in Claremont, because we were starting new. We had no traditions. And really, to make progress in medical education, you've got to get rid of the traditions. You've got to get rid of that mindset that we've always done it this way. So I do think medical education will change, but I think it's going to be one of the slowest parts of the healthcare system to change.
The next question says, do you anticipate that with the workforce and healthcare moving to a more virtual world, it will create challenges for medical professionals to gain employment where they were once in an office setting?
I don't think so. You know, I think this is an opportunity for us to be creative. Telemedicine is going to be a huge boon. I think we're going to see healthcare is shifted from the hospital to the ambulatory setting, and I think from there it's going to shift into the home. I think in the future we're going to see more things done at home. There are going to be more opportunities to remotely monitor people at home, to check on their biometrics. This is a growing field. Telemedicine is a growing field. Home care will be a growing field. There are going to be lots of opportunities. This is a chance for innovation. And entrepreneurial people will rise to the occasion and find new ways to deliver care in a way that's both compassionate and cost effective. That's the challenge for us in the 21st century.
Yeah, absolutely. So just to kind of start winding down, I wanted to ask 2 additional questions. What do you think is working well right now in the industry overall?
I think the most impressive thing about the industry is the way everyone is pulled together. I really do. I think that, as I said, this is an all hands on deck moment, and I think the vast majority of people have answered the call. So that is something that I'm very proud of, whether it's doctors, nurses, ancillary staff, whether it's the person that's answering the phones, the IT people, everyone's pulled together in this. So I'm very proud of what we have done and the way we have responded.
Great, excellent. And then the final question would be, so what gaps would you see being filled more quickly than others? When we're looking at the gaps in the system, what do you think is kind of that low hanging fruit that we as healthcare leaders could address more quickly than others?
Well, I think one of the most important things is to start planning for the second wave. We don't want to get caught flat-footed again. I do believe there will be a second wave. If you look back at the 1918 flu epidemic, the first wave was bad, but the second wave was worse. All of the protests and the rioting we're seeing have the potential to spread the virus. We worked really hard to slow the spread of the virus. People stayed home. It was difficult. It hurt the economy. And we were making preparations to carefully and safely open the economy again. And I think that these large gatherings of people have the potential to spread the virus. We could, in the next 4 to 6 weeks, see a big resurgence in cases. So we need to be thinking ahead. I think that's the most important thing that healthcare executives can do right now, is to think 4, 6, 8 weeks ahead. Where are we going to be? What do we have to do to be prepared if this thing comes back in a big way?
Yeah, absolutely. Well, great. Well, thank you so much, Dr. Molina. This has been a true pleasure to get to speak with you today. I really appreciate your time. So I'm just going to check really quick to make sure we don't have any other additional questions, and then we'll just start wrapping up. All right. Sounds good. So thank you so much for joining us. We don't have any other additional questions, but if anybody does, they can certainly kind of continue to throw them in the chat box, send them an email. We'll put the email link up at the end. So thank you, Dr. Molina, for joining us today and sharing your insight and perspective in the area. I really, like I said, I really appreciate you taking the time to explore these issues. If the listeners have any additional questions or we were unable to get to their specific questions for whatever reasons, I would invite them to email those links to the links that we're going to put up. And thank everyone for joining us today. Thank you. This has been such a great time and an amazing opportunity to have this conversation with our virtual audience and with you, Dr. Molina. I would strongly encourage you all to go to the website. Please, please, please check it out and learn more about NALHE and all the things that we're creating in the healthcare leadership space and for upcoming events. I'd also like to thank the NALHE leadership at the national level who've generously given of their time and resources to make this happen. They're an extraordinary group of people. I couldn't have asked for a better group to work with. They're amazing and their gifts and talents are greatly appreciated. So thank you so much, everyone, for joining us today. And that's all. So in the interest of being respectful of everybody's time, I'll give everybody back the rest of their hour unless anybody else has anything else.
Well, thank you very much. It's been a real honor to address the group.
Well, thank you, Dr. Molina. You have a wonderful rest of the day. Take care and stay safe.
Thank you.